Testing, 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 sound check, sound check, sound check, testing, 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 sound check, sound check, sound check. Good morning. Did you hear me?
Yeah, sounds good. Everything the way it's supposed to be. Nothing's been.
Nothing's
Swamped back.
weird. If you haven't already, before you decide on the induction, speak to your physician, because it does not come with no risk. Does. Good morning. Oh no! It happens. I did download this one. I think I've already got it. Yeah. There it is.
Did you grab the napkins that I put there for you? I'll get them in a bit. Okay, I want you, hey, how are you? Good morning. I want you in that corner, diagonal, all the way in the back. Okay. All the way. And at 7:20, I'm gonna send you to the bathroom, and then there will be no bathroom breaks. Hallelujah, I can't wait till my oldest gets back today.
Yeah.
No, she stayed, we went to see my parents last week, and she stayed with them for an extra week, which was super fun. This is her first time flying alone, so that will be interesting. Yeah. Okay, do you want me to pull it up? Yeah. Okay. Thank you. Holy smoke, I can't tell you how nervous I am about this. Like, I don't usually get that nervous about public speaking, but this particular topic has me on edge. Okay, wow. Okay. I'm just looking, I'm worried about the reaction. You know how it is.
Yeah.
My husband says they're wrong. That's going to be the only jerk it's been. That's what he said to me. I'm like, okay, that's a good point. Hey, you made it. Good morning. So you want to start with the poll, give people a chance to get on the poll first, right?
Okay.
And that's just kind of how we'll start the talk, I think. That's okay.
It was slow coming up when I downloaded it for my records. I think it's just this stuff.
That's okay. That's why we're here early. Okay. So it should. It still keeps this. That's weird, right?
That is weird.
It should. The whole poll should load any second. Start the presentation. I thought I started the presentation. Isn't that what I did?
That's what you did.
Try again. Preset.
I wonder if you have to download it.
Oh no.
I don't know.
Yeah. I think it might just need a minute. Because it took a minute for it to load.
Install the app or get help on
At polledeverywhere.com. I don't want to have two different browsers is the thing. How come? How do I say yes? Goodness me.
What if you say allow once? What does that
I
do?
did.
Oh, you did, and it's still didn't do anything.
Well, what happens if we do? See what it's supposed to do?
Mhm.
I can't see the thing. Is have up here text this number to, or this to this number. And then it'll, do you get what I'm saying?
Mhm.
But it's not telling people to do that. Shoot. Okay, let me try
What
it.
if you?
Yeah.
No, that's not going to help.
Why don't we have Drive on this computer? Do you know what I'm saying? Not that I had time to now start downloading it, but
I don't know.
that would do it. Here, I mean Chrome is what I meant to say. Because if I open it in Chrome, it might work, as opposed to Internet and Explorer.
Yeah, there's a lot of things that don't work in Explorer.
Nope, I don't want to add a person.
You should be able just to open it and then open your presentation. That doesn't make sense.
Browse as guest. Your browsing is guest. Okay, I'm fine with that. Glasses. Okay, go to Google Drive. This might work.
Hopefully.
I know. Fingers crossed. Okay, let's try it again. Because Poll Everywhere is a Google thing.
Mm-hmm.
So if I open it in Chrome, maybe it'll work. Come on.
I know people have used it in here before. So I
Yeah.
don't know why it's.
I just used it on Chrome at home like a million times. Start the presentation. I thought I did start the presentation.
Is there something else you have to?
Oops.
What if you download it?
Let's try that. I mean, I can't come up with anything else to do. Shoot. I keep forgetting what it is. Just open it and download it. Wow. Let's try. What's the worst that could happen? Okay, there it is. Just wait for it to finish. And then it's tricky. Sometimes it wants you to open it from here instead of from there. It's
Huh.
weird, I know.
That is weird.
Okay. Close that.
Okay, so what does this say?
Here.
Do enable.
Enable editing. So to bring this back over here. And then present. Where is present?
So, yeah. It's still not showing up. Still no live content.
You know, interesting, I deleted the app yesterday from my phone after I presented it. I wonder if I wasn't supposed to do that. Because it's saying download the app.
Hmm. I'll turn this off so people can't see it. until you're ready.
Yeah. Oh, that's me joining is the thing. Sign in the profile. Continue. That one. Okay. 1, 2. So, can I, if I go like, if I flip back and forth, will it change what's up there?
Flip back and
Or
forth.
can I close and open is what I can do, right?
Yeah.
So let me close this out here. So, and then I don't need this over here. I have another idea. This is what we can do. Close this. And then, and over here, close. That's fine. And what I can do is have pull everywhere open and then just close and open. Do you get what I'm saying?
Mm-hmm.
So log in. And then I'll just have to pull up each poll individually. Do you see what I'm saying?
Yeah.
Which I don't mind, that's fine. My talk is 40 minutes long.
Okay.
Yeah. So then I just start with this. And then here what I do is I start when I'll present from here.
Okay.
Right? And then there.
Okay. So everything, you can look at this and nobody sees this. For anybody to see it, you have to drag it over here.
Oh, okay.
Okay.
So how do I do that?
So click up here.
I see what you're saying. Okay.
And then you can minimize it and it should, so minimize it and then
So what I can do is I'll go
it
like,
should come back up.
I'll flip to this and hit present. And then when I want to do a poll, I'll go to this.
Yes.
Is that fair?
Yes.
Okay.
Okay.
We'll
So
just do
one
it.
other thing you need to be careful of.
Yeah, is don't move
You
my
see,
hand. Yeah.
you see how this comes down?
Yeah.
Don't hit stop presenting
Okay.
because everybody on Skype will
Can't
go
watch.
away.
Yeah. That's
And
fair.
then it'll take me a good 5 minutes to get back
I'm sorry.
up.
I won't do that.
So just be aware of that.
Okay.
So I'm going to minimize you here.
Okay. Well, I want people to walk in and start.
Okay.
Yeah, because
Okay.
more than anything, what it'll do is get people already logged into the poll,
Okay.
right? So that they'll take less time throughout the talk to do that. So I'm just going to run.
So you want me to, this is what you want?
Yes, this is how I want to start.
Okay.
Yes.
So let me turn the screens back on.
And that's what should show.
Okay. Just a couple quick things.
Yes. Talking to the microphone.
You can circle
Yeah.
if you need to, but the people on Skype only hear from that.
Okay.
And so if you circle way too far, they can't hear you.
Okay.
Repeat any questions the audience has at the end. And be careful of that.
Yep.
Use your mouse as a pointer.
Yep.
That's it.
Okay.
So you can go to the bathroom.
I gotta get them. Okay. Thank you so much.
You're welcome.
Rushi, can you hear me? This is Jenny.
Yes, we can hear you.
Good morning.
Good morning.
Just tell Rushi that Jenny's watching.
Okay. Oh, you found your stamper. gonna move up.
Yes, I actually saw her yesterday, so I said, thank you so much. And
I did too, 'cause I was just, but Tom was like, oh, that's too short notice, but I'm gonna work on it, so next time you call me within 24 hours, I can do it. I'm like, okay. He said, I didn't know you were serious, and I'm like, yes, I'm serious. What you guys do? There. No, well, I don't think that's what
or you mean the dates?
they, either one. They're not gonna switch the dates. They were like, no.
What opening do you have now?
So now we have the last one in August, the last Friday in August. Is what's open.
Because I was.
That was her.
To Napoli there.
I can't.
Doing those 3 set dates. Do you remember? Because you were gonna move.
I think it's
A week or 2 after that, that was in September.
I can't swear to it.
Yeah, that's fine, that's fine, but if we can get to Napoli there.
I can ask him. I'll ask him.
And then just, when
They're November the 1st.
Okay, they already have.
They already have a date. So, the thing is, the meeting being on Monday, so far,
That's why
and
that's why
that's
you So
So I don't know if you want to,
Maybe we should.
Not
do a-
me-
yeah,
an email vote?
yeah.
I did see Laura, I don't know, I did hear another name for Lauren, and she says, I have credit. I'm
No, let's do it by email. Because we don't sit here and be like, okay, what do you want? And then
Yeah.
none.
Okay.
So let's do it by email.
Okay, so send it out, when will we have them have it back? Because I have to get the award.
Before the end of next week.
Okay,
And then we can, the following week, we can do the award. Is that too short?
I don't know. I'll have to ask the people that create it. They have my template, and all I'll have to do is really just change the presentation, the year, and the speaker. So I think we probably can, but I will verify that. So I'll go in, I'll cancel the meeting today. And I'll send the information to everybody, and I send it back to us by Wednesday. Good? Okay. So I will do that today. And then the next opening after the end of August is October.
Yes.
So we have to work on the end of August.
Yeah, there's kind of a couple few things maybe we talked about, but I don't know if anybody's really interested.
When was the last time this government finished for?
Oh, I saw that one.
That award, right? That was February
Of 18, yeah. So it's been a
He
might.
here, and I ran over to the next door neighbor, they were just
It's about a year ago.
their house, and I got a
On
flat
the
tire.
importance of having
So,
genetics.
anyway, we're Friday.
How do you work around it? Great.
Yeah. Oh, so she's at your house now? Yeah.
Since he already has it? Okay, let me know.
Yeah. I'll think about it.
That would be a good fix.
Yes.
Okay. She did as well. Course for, when we not about exhibit, hands-on, doing but you know, they don't. Oh, interesting. Yeah. The very first part. So I need to go see that. And I have to go to Bristol too. Now, I can never have special. Oh, they do? Well, the really also, although they had a,
So like if you go to the other, go to one of the other, so I have it in there, and when you hit present, actually go to the slide from my first one. You hit present, then it keeps saying this, it doesn't actually start presentation. This isn't fun. It never stops there. And like when I text it.
Did you try
Downloading it and doing it? We did. Good morning, Dr.
Good morning, what made you do?
That would be fantastic. Is that okay?
Absolutely. I have the goodies.
Thank you.
Same from the beginning.
I'm really bummed because I have like 5.
But it goes to this
Right, and then you have to
screen.
drag it, which is fine. I can drag it, but it doesn't even work. It doesn't actually
Audrey, how are
It'll
you?
present my talk, but it won't actually ever.
So what I've done with polls everywhere in Google Slides is download the presentation.
Okay, and I did that too. So if we
As a
just go-
PowerPoint or as a...
Yeah, it's on that side, but go ahead and just download it again. Yes. And I'm fine with that too. I don't mind if it works.
Well, sometimes from Google Slides to...
It doesn't, right? That's why I was using it. See, so it does the same thing. Oh, it just said I joined.
Mm-hmm. So can you vote?
But where did I join? Let's see. I wonder if I joined in the Google Drive. I can't respond to this poll anymore because it closed it on the other one. So it's not this that's working, right? So let's close it again. It's this one we want to present. No, that's working. It's working.
Okay, so you
I'm
want to
just
leave
going to
it
leave
there?
it in poll everywhere.
Yeah, so let me reset this. Clear results.
Okay, and then we'll start over again.
Okay.
So I'm going to try it again. You can't respond anymore. Very good. It's working.
Do you know how to handle this part?
Yes.
Like the dragging and so...
Well,
so
it's drugged. It's already drugged over here. I don't need
Okay.
that anymore at all.
Okay. I'm going to be there in case there's panic or
I give you this.
yes.
Okay.
Okay. Very
Thank
good.
you.
Yeah.
Thanks a lot. I appreciate it.
Sure.
It's not too long now that you are coming in. I almost was like, maybe I'll just use myself, and I was like, You don't worry about this. Somebody else has got some rubbish.
Good morning, everyone. Welcome to Pediatric Grand Rounds at the Children's Hospital San Antonio. I'm going to ask Dr. Gilbert to come to the podium to introduce the speaker this morning.
Good morning. This morning it's my pleasure to introduce Dr. Ruchi Kochik. She is an assistant professor of pediatrics here at Baylor College of Medicine and medical director of the Complex Care Clinic here at the Children's Hospital San Antonio. She attended Dayanand Medical College and Hospital in India for medical school, completed her residency training in pediatrics at Women and Children's in Buffalo, while simultaneously receiving a master's in public health from the University of Minnesota. Prior to taking a position here, she worked as both a hospitalist and primary care physician at Boys Town in Omaha and Mayo Clinic in Rochester, Minnesota. She enjoys teaching, I think we know that, thanks for us, as a rotation director of the Complex Care Rotation and Community Pediatrics and Advocacy Rotation, as well as the Healthy Beginnings Rotation here at the Children's Hospital. She is passionate about building collaboration across primary care, public health, and community-based organizations as an advocate for all humans who need one. Her efforts to raise up those voices are often unheard, inspired our residents. And last year she won the Ozzie Regaria Humanism in Medicine Award. I can't think of a more deserving person, nor one of my favorite people, Dr. Ruchi Kochik.
Thank you, Dr. Gilger. I hope everyone can take a quick moment to log into the poll. I have about 5 or 6 poll questions throughout the talk, and I'm curious to hear what our institution feels about this topic. So I'm just going to give everybody a minute to answer this first poll question. So if you want to text to Ruchi K 202 to 22333, you can participate in the poll. Okay, I can see people are getting on there. Okay, 1 more minute. Okay. So I think this poll just in the room itself shows that this is a topic that I think is relevant to our audience. I'm going to have to flip back and forth between screens, so I apologize for that. But I'm excited to present a topic that is relevant to everyone in the room and all subspecialties. Sorry, it looks like I have to drag this over here. Oh. To present. Okay. Gender bias in medicine. Okay, I have no financial disclosures. I'd like to start by telling just a quick 2 short stories about my own life so that you all understand why I'm interested in this topic. About 9 years ago, I walked into a children's hospital in a city that I lived in with my own daughter, who was 5 at the time. She needed an MRI of her spine. We stood in line at registration, which really consisted only of us because it was super early in the morning, so it was just me and my daughter. And the lady at the registration desk had her head looking at some papers, and so I waited until she called us up. And without lifting her head or looking at me or saying, "Good morning, welcome to Children's Hospital," she asked, "Do you need an interpreter?" And that was really eye-opening for me. It was certainly not the first time that something like that has happened, and it's not going to be the last time. But it happened at a time where something else very similar happened in my life, so I started to think more and more about implicit bias. I was seeing a 5-month-old boy for one of my partners. It was my partner's patient. And he had a fever with no source, which, as many of you know, if you have a fever with no source at 5 months of age and you're a boy, you're likely going to get blood and urine drawn. And that's what we talked about. And the mom, a very lovely lady, petite, with blonde hair and a high-pitched voice, was unsure of my recommendations. She didn't believe that that's what we should have done and said, "Can I talk to my husband first?" And I said, "Absolutely. Why don't you give him a call? I'll give you a few minutes." I turned around, and I didn't say this out loud, but in my head I said, "Wow, you can't make a decision for yourself. That's really unfortunate," and left the room. I went out, I started getting some things together, came back in, she was on the phone with her husband, she put him on speaker, we talked, answered a couple questions. Turns out he's a dentist, and so had some very relevant questions. They agreed. I left the room, went to the nurse to try to get some cath supplies, and it became known to me that the mom is also a dentist. And I was mortified because I had done to somebody what many people have done to me and thought, wow, I can't really expect other people to treat me the way I want to be treated if I myself am not treating people the way they should be treated. So let's start talking about, before we get to the objectives, what we're not going to do today. So this is not a Me Too or a Time's Up talk. Those are certainly very important topics: sexual assault, sexual harassment in the workplace, very important. But we're not going to talk about that today. What are we going to do? We're going to define implicit and explicit bias with particular attention to gender bias, discuss the current literature that identifies that gender bias in the workplace is present, particularly in the field of medicine, and appraise the various solutions described in the literature to mitigate gender bias and ensure gender equality in medicine. Okay, so starting with explicit bias, these are the attitudes and beliefs that we have about a person or a group that we have on a conscious level. It's often in response to a perceived threat. We feel threatened by a certain person or a group. We draw a line around ourselves and other people that are like ourselves, and we do this very consciously. Implicit bias, on the other hand, are attitudes, beliefs, or stereotypes that we have about a person or a social group without our conscious knowledge. And the mind sciences tell us that many of our implicit biases are what rule how we make decisions every single day. They rule how we make decisions far more than our explicit biases do. And if you're not really 100% sure about that, I want you to think back to the last time that you drove home post-call as a resident. Many of us don't remember how we got there, but we just did, right? And then gender bias is a preference or a prejudice of one gender over another, whether it be implicit or explicit. And today we're going to talk about implicit gender bias. Okay, so before we start talking about a topic about assumptions, we're going to start by making a few assumptions. I see the irony in that. I also see the irony in the fact that all of my slides are pink. It just sort of happened that way. But the first thing I want to say is everyone that's in this room is interested in this topic, right? If you weren't, you wouldn't come and hear out what it is that I have to share today from the literature, right? So I'd like to create a safe space because I hope that by the time I'm finished and you've seen all of the literature, we can create a discussion and toss around some ideas within this room itself the last 10 minutes. And I want this space to feel safe. All of the biases that we're going to discuss are implicit. It's very possible that no one has brought this up to you or to your attention in the past. You're unconscious of it. It is not explicit, which means it doesn't necessarily mean that if you find that you've made a decision or an assumption about somebody, that you are prejudiced or are likely to discriminate knowingly, right? So this is not about blame. This is about let's identify within ourselves, just as I took some time to soul search and identify within myself what my biases were, so we can create the conditions and an environment and a culture, a place where all genders can thrive in the workplace. Okay, so we're going to go to the poll again. So hang on a second. Let me find my... Okay, so I showed you a picture of a woman. Sorry, it took 1 sec. Let me take a second and show you the picture of the woman again. So just take a look a second. Who knows who this woman is? Interesting, very interesting. Ooh. Just another minute. Oh, somebody has a hand raised.
It's not Rachel Carson, is it?
No, it is not Rachel Carson. I actually don't know who that person is, so thank you for bringing that person to my attention. I'll go look it up. Okay, and now I have to find my talk again. Sorry. Oh, I don't know what I just did. Here we go. Okay, here we go. So this person is Katherine Johnson. Does everybody know who she is now? She is was a NASA physicist who calculated trajectories as we were starting to put together the first flight to put people on the moon. She was portrayed by Taraji P. Henson in the recent movie Hidden Figures, right? But many of us don't know who she is. We're going to do another poll, which of course takes me to this. Okay, so going back to this picture, who is this woman, or what is this an image of? Yeah, oh my God. Awesome. I like Black Hole Imaging Queen. So what we're going to name her. Great, awesome. Okay, so I think everybody catches on to who this person is. So we'll just go back to this. This is Katie Bowman. She is, so interestingly, when I went to look her up so I could introduce her properly, she is one of a group, a team that at Caltech first imaged the black hole. So I say it that way because when you Google her, that's how it's described. She is a member of a team that did this. But when you look up Watson and Crick, you don't hear about teams, you hear about Watson and Crick. And the third person, Maurice Wilkins, who also won the Peace Prize, the Nobel Prize for discovering DNA, is not mentioned till very far down. And Rosalind Franklin, who someone mentioned earlier in the previous poll, you really don't find for a long time, and she did not win the Nobel Prize. So, okay, so why are we susceptible to implicit biases? Because we tend to seek out patterns. That's how our brains work. And we like to take shortcuts, mental shortcuts. We as physicians know that better than anybody because we have a ton of information to learn, and it's really helpful for us to create patterns and take mental shortcuts so we can move through our algorithms to identify a diagnosis and start treating someone, right? There's also the piece of experience and social conditioning. So the way you were raised, right? The way the media has portrayed men and women, and the personal, interpersonal relationships and experiences that you've had that sort of guide how you decide unconsciously how things are going to move forward in every situation that you have with that same gender. Okay, the group, so we're going to start by talking about the state of women in academic medicine today. The group on women and in medicine and science and the Association of American Medical Colleges does a survey every few years to look and see where women are currently in academic medicine. And what we find is that in terms of applicants, matriculants, graduates, and residents, women are approaching parity. We are roughly in the high 40% in terms of the number of people that apply and go to medical school and graduate and become residents. But as soon as we start seeing full-time academic medical faculty, that number drops to 38%. of faculty. Now, the highest number of applicants and matriculants that we saw was in 2003 to 2004, where it peaked at 51%. And since then, it's sort of leveled off in the 46 to 48% range. But even still, 38% of full-time academic medicine faculty are women. And then once they graduate, what is it that they choose to go into? By and large, it's OBGYN, pediatrics, family medicine, psychiatry, and pathology. And far fewer women go into internal medicine and the internal medicine subspecialties, anesthesiology, emergency medicine, and surgery. When we look at full-time and part-time, far more men work full-time than women do. Interestingly, we don't see that 100% of men are full-time workers. There's still a gap there, and the reasons are a little bit different. So when women choose to work part-time, it's likely because they want to take care of their young children or their dependent adults in the home. Whereas when men take part-time positions, it's because they hold a position somewhere else. And when they add up all of the FTEs, they do equate, sorry, couldn't find the word, to 1.0 FTE. What about faculty rank? So there's still a significant low proportion of women that have attained associate professor and full professor. We are approaching gender parity in terms of assistant professor. The only faculty rank we see where women outweigh men is at the instructor level. And then we see another fall in terms of proportions when we look at permanent leadership positions, particularly at the dean level. We are seeing a rise in the number of women that are deemed assistant deans. There was a little drop in the 2013-2014 survey, which I'm hoping is related to the fact that there was a rise in associate dean leadership positions. But as you can see, we have a lot of work to do in leadership positions. So what about pediatrics? So I showed you a lot about the different specialties. Let's bring this home and talk about our own specialty. We know that there are a total of 129 department chairs across the country for pediatrics. 70% of pediatricians are female, and 20% of department chairs around the country are female. So what is the take-home message? We are approaching parity in terms of women applying, matriculating, and graduating from medical schools. We are losing women in terms of the academic workforce for a variety of reasons, and we have much work to do in terms of leadership positions. Why do women leave the academic workforce? A lot of times people like to start with the pipeline and that we're not putting enough women into the pipeline. That's actually not the case. In the next several slides, I'm going to make the case for the fact that the pipeline is actually leaky or blocked. Many women will say that there are many off-ramps and not too many on-ramps. And then again, in the next several slides, I'm going to talk a little bit about how the labyrinthine maze is created for women that is very different for men. One study looked at the deans of 83 US and Canadian medical schools and asked them their perceptions about why they feel women are leaving the academic workforce. And they found that there continued to be a lack of appropriate representation of women in senior positions. They found that a condescending attitude towards women among much of the faculty continued to exist, and that time alone, and this is a key point, time alone was insufficient for women to make up and catch up to find those leadership positions, and time alone was insufficient to change the environment that women worked in to allow them to attain those leadership positions. And I say that time alone piece because a lot of times we'll say, well, there was this 5 to 10 year period where women took a step back because they had to care for their young children or their dependent adults, and as soon as they re-entered the workforce, they were able to catch up. But these deans, these 83 deans, did not feel that that was the case, that time wasn't going to be the factor that allowed them to do that. Some of the benefits and policies that they named that would help women foster gender equity were benefits for part-time, paid maternity and paternity leave, salary equity analysis that was shared regularly with their faculty, child care facilities in close proximity, and this wasn't studied in this particular study, but I would add child care for when your children are sick, when you have easy access to child care when your children are sick, that certainly helps. Search committees that mandate female representation, recruiting dual career couples, tenure for part-time faculty, incentives to hire women. optional or automatic delayed tenure for if you have a child or special family needs, and the mandate for at least one woman finalist for each search. These were all benefits and policies that would support gender equity in the workplace, these deans felt. So what do we do as a society that perpetuates gender bias? Okay, so we're going to do another poll because this is fun. I hope it's fun. All right. Okay. Oops, I don't think this is the one I wanted. Hang on. It will come later, but that's not the one I wanted right now. Okay, so we're gonna start with just the men in the room. Do people address you as doctor when appropriate? And I say when appropriate. When we're talking to one another, that's a different story. But I'll give it a minute. Oh, that's interesting. Okay. Okay, good. Now, let's see if the next one is the other one that I wanted to. Yes. Now the women in the room. Do you believe that women address you, that people or your colleagues address you as a woman, as doctor, when appropriate? Okay. I'll give it a minute. The only way I can know that multiple people are signing in is if somebody says yes, and so I don't know. I don't actually know if anyone's saying yes. Yes.
It's a bit challenging since it's so dichotomous because there are, I think it's definitely, there are times where yes, I am stressed as a doctor, but then there are many times where I'm not, so it's kind of hard to pick one of the two. Yeah, sometimes.
Yeah, I wish there was a sun. I'm sorry. Next time I do this talk, I'll add a sentence sometimes to the poll. It's a good point. Thank you for sharing, though. That's actually what I'm looking forward to at the end of this talk. Somebody said yes. That's fantastic. Okay, great. I really like to foster a conversation when we're finished here. Okay, so what's in a name? So looking at these two black belts, the lower black belt is my black belt that I earned with my 3 children in December of this past year. The top black belt is my husband's black belt that he earned just last month. We go to the same Taekwondo school. The Taekwondo school actually knows that we're both physicians, did not ask us how we wanted our names and our black belts, and this is what we got. Okay. In fact, the Taekwondo instructor has asked me questions about his children multiple times to get curbside consults. Anyways, okay, so that's a very anecdotal comment, but on a grander scale, the Mayo Clinic did a study of their 2 sites, the Scottsdale and the Rochester, Minnesota site, to look at how individuals were introduced at internal medicine grand rounds presentations. What they found was that for over 300 introductions, 96% of the time women introduced their colleagues as doctor. 66% of the time men introduced their colleagues as doctors. Women introduced women 98% of the time as doctor or professional title. Men introduced men 74% of the time as doctor or professional title. Women introduced men 95% of the time as doctor, and men introduced women 49% of the time as doctor. So what does this do, right? So that it creates 2 biases. The first bias is the lingual expectancy bias. This is a reinforcement. If you already hold an implicit bias that women do not belong in professional positions, or you haven't seen women in professional positions, this lingual expectancy bias just reinforces that. It also creates something called the in-group bias. So when men introduce men by their professional title, they've created their group, and they surround themselves as that group, leaving women outside of that group when they're not introduced by that title, and it diminishes women. The other term for that many of us is the old boys club, if you will. Okay. Okay, what about letters of recommendation? One group of researchers looked at over 300 letters of recommendation for 103 applicants to academic faculty, successful academic applicants to a faculty position. There were 29, about a third of them were women, the applicants, and almost 3/4 of them were men. The people who wrote the letters were by and large men, which makes sense because I just shared with you that division chairs and department heads typically are men, so you're going to go to your department chair to write a letter for you, who's probably going to be a man. And the people that were receiving these letters were by and large men too. And interestingly, when you look at this, so we've got this in-group method again, right? When you look at about 40 of the letters, they actually address them by first name because they're friendly, they know each other, and they've created that in-group feeling. What they found was that letters that were written for men were 4 times as likely to highlight multiple professional titles beyond the term doctor. So we're going to step away to this another poll really quick, and then I'm going to come back and expand on that topic of the recommendation letters. This is essentially the end of the polls. When you think about Oprah Winfrey, what sort of leadership qualities come to mind? Just pick one leadership quality that pops into your head when you think about Oprah. Oh, I like the money one. Empathy, very nice. Okay. This is really nice. I like this group of adjectives that we're identifying. Good, 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 good. Confidence, very good. Okay, we're gonna go, and then we are gonna actually do the George Clooney one too. Okay, and now remember, we don't have to comment on physical appearance. Please find an adjective that describes George Clooney that does not relate to his physical appearance. Yes, I think of them all too when I think of George Clooney. Batman, I love it. Horrible, oh no. Okay, I want to talk to that person and find out what makes them think he's horrible. That's great because I'd like to learn more. Interesting. Okay, so charisma, philanthropy, insurance. Is he on a Humana ad? Did I miss? Okay, very good. Thank you, everyone, for humoring me and participating in all of my polls. Where did I lose my? Here we go. Okay, so why did I pull out adjectives for 2 leaders? It's interesting, actually, we found very similar adjectives for both leaders, and I think that's fantastic because what I share with you next is going to perhaps jilt you a little bit. When we looked at those letters of recommendation even further, the personal pronoun her was found in front of training, teaching, and application, and the personal pronoun him or his was found before research, skills and abilities, and career. And this then created this belief that women were teachers and students and men were researchers and professionals. They also found that these letters were more likely to refer to women's personal lives, and they were more likely to refer to men in terms of their publications, their CVs, patients, and colleagues. Let's look at so we talked about introductions, we talked about letters of recommendation, we're going to talk about evaluations now, which I think is really going to hit home because we write a lot of evaluations, right? So they looked at, there was a study that looked at over 1,300 attending comments for women and men that were emergency medicine residents. And what they found was that female residents received less consistent feedback about their various qualities and traits. And that was within the same evaluation and between evaluations. So I want you to imagine getting an evaluation that comments on your skills in a positive light, and then in the same evaluation comments on your skills in a negative light. Which are you supposed to accept, and how are you supposed to change when you don't even know what is what, right? And men tended to receive more consistent feedback. Women did receive more strong praise and strong criticism, but they were less likely to get no negative comments. In fact, there was only one woman who had no strong criticism and no negative comment in her evaluation. There was also a finding that women were more likely to lack valued emergency medicine personality traits like takes charge, takes initiative, is proactive, is confident, does not complain. And all of these adjectives that I just described to you have been proven in other studies to be considered masculine traits. Another study in the Harvard Business Review that looked at 81,000 evaluations for over 4,000 military personnel found that there were no gender differences in objective measures between men and women, meaning their grades, their class standing, their fitness scores were equivalent. There were no gender differences in the number of positive attributes, but that women were assigned more negative attributes. And I actually want to point out these adjectives because I think they make a point. So you can see on the left are all the words that were used to describe men in these evaluations, and on the right are all the words that were used to describe women in the evaluations. And so analytical, competent, articulate, logical, practical, these are leadership qualities, right? There were fewer negative terms. And then when we look at I want to start with the negative terms for women. I want you to think about how they reinforce our implicit biases. When women have an interest in pursuing a career in leadership, they're often considered selfish. When they have comments to bring forward, they're often considered gossipy or temperamental. If they have a reaction to something, they're panicky and scattered, excitable, right? Let's look at the positive attributes for women: compassionate, enthusiastic, energetic, organized. I think these are all great traits. They're wonderful, right? Yeah, and frankly, if I don't have compassion, I couldn't do my job. I mean, my job relies essentially on compassion and empathy. But now I want you to think about 2 letters of recommendation that are written for a man and a woman who are both applying for a position of dean. If you see analytical, competent, logical, and practical in one, and compassionate and enthusiastic in the other, which are you going to pick for dean? Okay, so what are the consequences of all of these studies that I've shared with you? Well, starting with academic leadership. At the beginning of the talk, I shared with you that women are approaching gender parity in terms of applying to medical schools and graduating, but we find this drop to about 38% of faculty, and an even further drop when we look at academic leadership. When we look at grant funding, women and men have reached gender equity in terms of how much funding they receive, but women have far fewer publications, and those publications have lower impact factors. In terms of academic productivity, when women and men apply for grants, women have to work 2.5 times as hard to win those grants as compared to men and to get the same competence scores. And they measure that by the number of publications and what kind of impact factor they have on those publications. One study through the Freedom of Information laws at Harvard found that women on average earn $20,000 a year less than men for similar work once they've controlled for various factors. And then finally, patient care. Many of you may be aware of the study that was published in JAMA in 2017 that showed that elderly patients who were cared for by women had lower 30-day mortality rates and 30-day readmission rates. And when we have a workforce that has driven women out, we lose the opportunity to learn from their practice patterns that can then care for our patients better. Okay, so I spent the greater part of the last half hour sharing with you what the problem is. And I think when you've had a chance to poll yourselves, you have identified that there is an issue. Now, what can we do as a society and as individuals to pursue solutions? We're going to start talking about what we don't do. So we can't put our heads in the sand. And I really hope that over the last several slides, I've been able to share with you that this is certainly an issue that needs to come to light even more than we have today. We can't put our heads in the sand and assume it's not a problem. What you could consider doing, if you still don't believe me, is take the implicit association test that Harvard's put out. So I've taken the test twice, once for gender and once for race, and I was really surprised. I apparently don't have bias in terms of race, but I do have a slight bias and preference for men in terms of professional roles. And I was a little bit sad to see that. Raising 3 daughters, I was a little bit sad to see that. Okay. We can't tell people what to do. No one likes to be a puppet, right? So, and we know that more than anyone. We as healthcare practitioners are autonomous and love our autonomy, right? Please don't tell me what to do. I love the way I practice medicine. I'm going to do it that way. And it actually is shown in studies that when we implement gender diversity or diversity sensitivity training, including the implicit association test, we actually decrease diversity. We find that more people are treating minorities and women unfairly, and we create something called the illusion of fairness. So one of my previous academic centers that I worked at, I am now in retrospect after 5 years realizing that's sort of what happened there. There was a huge move to improve gender equity and racial equity, and there was this illusion of fairness. And what that does is if people find that they've been treated unfairly, they're less likely to speak up because everyone already thinks that we're being fair because we have all these gender diversity classes that we're taking. Okay, we can't assume that the issue is that we're not putting enough people in the pipeline. Child psychology studies have found that girls perform as well, if not better, in STEM subjects in school, and that they're interested in STEM careers. What the issue is that through recruitment and selection, hiring practices, evaluations, promotions, leadership, training, compensation, women are being driven out. And we could assume that it's what we call the motherhood penalty that's driving them out. And many of us do take a break to take care of our young children and sometimes dependent adults. But if that were the case, if the motherhood penalty was the only reason, then we would see equity in terms of men of color in academic leadership positions, and we're not seeing that. We can't assume that we work in a meritocratic society. Many people will push back against gender equity solutions because they say, well, we're in a meritocracy. If you deserve this position, you should get it. But from the slides that I just presented to you, it really isn't a meritocracy. And there are a lot of policies that are put in place that make it difficult for women to have an academic position or a leadership position. So we have to move away from the idea that it's a meritocracy. Okay. Has anybody read Lean In? It's a book by Sheryl Sandberg. Or Brag, The Art of Tooting Your Own Horn Without Blowing It. It's another really good book. They're both great books. The only issue I have with them is they perpetually tell women how to negotiate better, sit at the table, become more assertive, ask for what they want. These are typically considered masculine traits. They're great traits when we're looking at men. Unfortunately, they are different adjectives when we're looking at women. Adjectives that I can't actually say out loud here, right? We've all heard them. So we can't expect women to change. We can't expect them to change their personalities because it's a catch-22. If we ask them to do that, we end up admonishing them for that too. And there are some personality traits that just can't be changed. So how many of you are familiar with the tiara syndrome or the imposter syndrome or the Princess Diana syndrome? Raise your hand. I've had all three. So the tiara syndrome is, and it's very often taught to young girls when they're in school, you just get good grades, sit down and wait, somebody's going to give you an award. You just wait. Somebody's going to put that tiara on your head. The imposter syndrome is, oh gosh, they're going to catch me, I'm a fraud, everyone's going to notice that I don't know what I'm talking about. That's a very classic syndrome. And then the Princess Diana syndrome is, I want everyone to like me. I want everyone to like me. And it takes a long time for women to step out of that and realize it really just doesn't matter if I'm liked. It just matters what I'm saying, that it moves everything that we're doing forward in terms of patient care, education, etc. We can't expect women to make those changes out of those syndromes and now suddenly become assertive. Instead, what we need to do is create a culture and an environment that prevents gender bias to begin with. Oh, sorry, too fast. Okay, so what can you do as an individual? Well, you can recognize that you carry an implicit bias. We all do. It is a fact. It does not mean that you are more likely to carry explicit bias. You're not more likely to be discriminatory consciously, but you may be doing it unconsciously and you don't even know. So take the test. Be mindful of gender stereotyping language. So this is something you can do today because today is the last day of the resident rotation, and so evaluation reminders will be coming out. Be thoughtful in how you write your evaluations. I mean, certainly I love calling our residents compassionate, but man, is that really a trait that promotes leadership, right? When you're writing letters of recommendation for your colleagues, think thoroughly about how those are going to be read for the positions that you're writing for. Embrace sponsorship. So sponsorship and mentorship are different. We all value mentorship, and it's fantastic. Sponsorship is different in that this is a person. A sponsor is a person who may be male or female who sits at a table, a big table, a table where many big decisions are being made. And when something comes up, an opportunity comes up, we're on a search for candidates, that sponsor speaks up and says, I have a candidate. I know someone that I think would be great for this job. And sponsor women and men equally to attain these positions. Treat gender equality as an innovation challenge. Okay, so again, as scientists, we love a great challenge, right? We love the opportunity to find something novel and then go tell everybody about it. So do that. So come up with your own idea of how you can improve gender equity in your own division or department. One example, there was a study of a North American university that looked at evaluation practices. And they had a bunch of evaluations with rating scales 1 to 10 that they put out. And they found that far more men attained a rating of 10 than women did. It was very difficult for women to get that rating of 10, and it's really because we have this idea that 10 is perfection, and that men can attain that perfection, and it is elusive for women to attain that perfection. When they changed the rating scale to 1 to 6, they found a whole lot more equality in the number of people that were getting 6 between men and women, because now that perfection has been taken off the table. Expect transparency. So we should expect transparency from our organization in terms of salary, in terms of hiring practices, and in terms of academic promotion. Change institutional norms. So as we encourage and expect our young residents to achieve leadership positions or achieve faculty rank, we need to have more people in those positions that serve as role models so that they have something to look at and say, I can do that one day too. I would say this to people that train medical students as well or teach medical students as well. If a medical student is interested in a surgical field, it is the onus is upon us to help pursue that for them if they're interested in a surgical field, because it doesn't have to be just men pursuing those fields. Create a culture in which people feel personally responsible for change. So again, we don't like to be told what to do. Let's put it in the department and the division chair's hands. We offer them the opportunity to say, I'd like to see what your department can do in terms of achieving gender equity in promotion or in leadership or whatnot. That, number one, assumes that gender bias is an issue. And number two, it gives people the autonomy to do it the way that they think is going to work for their group. And then implement those behavioral guidelines. So we're talking a lot in the abstract right now. One action could be the next conference that you put together, you assure that 50% of your speakers are going to be female. That's an action plan. And then hold ourselves accountable to it. Collect the information. Did we actually achieve that? What was our failure? Be empathetic with the failure and realize that we're not going to succeed in a day, and that's okay. But what can we do differently to move forward? How can we as an organization hold ourselves accountable to creating the conditions and the environment in which every gender can thrive? That's all I got. Okay. I would really hope, and I'd like to stand here and give everybody an opportunity to open a discussion. Does anybody want to share their experiences? Because I could say I have probably 20 million experiences I could share with you, but you don't want to hear from me for the next 15 minutes. I'd love to hear other people's experiences. Yes, sir.
My mother was a woman who was pretty smart, happened to be Norwegian. Norway figures in the top 5 of quality of life measures, longevity, health, economic prosperity. The Save the Children organization rates Norway as the best place to be a mother. We can't all move to Norway, but maybe we could study to be more like Norwegians and be better off. Remember, Leif Erikson got here 500 years before Columbus did.
Thank you for that comment. Thank you. Yes, ma'am.
I'm curious, did you send that belt back?
I did not. I wear that belt proudly.
But you could have had, you could have had it changed.
Yeah, I could have. And I could have. And I probably would have been a better role model for my daughters had I. I think I was just so excited to get a black belt. Just put the gosh darn thing on. I think the other thing is, it's an interesting point. It did cross my mind. The other thing is, when we're in class, because we go as a family, the instructor yells at my husband as Dr. Koshik. But then if he yells Dr. Koshik to both of us, we're very confused on whose turn it is to kick the board. And so he calls me Dr. Mrs. Koshik. And so I guess I understand. I mean, I don't. Maybe I need to hit another age milestone before I start doing things like that. Anybody else? Yes.
Back to the poll about how often you get addressed as doctor versus not, and as I was saying, it's really all over the place. I do think that for sure that is one of the reasons I wear a white coat when I'm around, is because I get that a lot less when I'm wearing the white coat. And another, it's just kind of I've noticed in the past that there are many times where if I'm in the room with even a male medical student, they frequently will get addressed as doctor more frequently than I am as an attending.
Agreed. Yes, sir.
So there's been a couple situations where, let's say there was a specific situation I was on at night where the family was upset and said, I haven't seen the doctor all day. Well, the day teams have to be all day. How can we address those families and kind of, because part of that needs to change too. That's a culture thing, might be outside the scope of this model. But what can we say as men, as physicians, to kind of start playing that scene?
Yeah, that's certainly a tough one. That's happened to a lot of women. I think some places what they've done is they've actually put up on the whiteboards pictures of the providers that would be coming in that day, and then writing out Dr. So-and-so. I think we need to remember that introducing ourselves as Dr. So-and-so and shaking hands with that eye contact, because people will remember that, as opposed to us standing there saying, I'm Dr. So-and-so, we're going to get started, right? Because people remember that eye contact and that handshaking, and that brings it to them. Repeatedly introducing ourselves will be helpful. I think, and I've seen this across the board, we're very comfortable with introducing ourselves with our first names, and I think that becomes difficult too. So there are a variety. I look forward to an innovative way to try to do that. But I have seen some places where they put pictures up and then write Dr. So-and-so next to those names, and that helps.
What did you say?
I said, so I found out who the team was, and I said, oh, you saw the doctor. I said, oh, you saw the, I addressed the concerns. They did have some other concerns about it. So I addressed those first, but then I was like, they will be in tomorrow. Doctor say they will be in tomorrow.
I come from the most under-female represented specialty in all of medicine. The current statistic is 6% of board-certified orthopedic surgeons are female. Even neurosurgery and urology have surpassed us. We didn't always used to be last, but we are now. And I'm a member of a number of social media groups. We have one called Women in Orthopedics that has over 1,000 women. As long as you're at least in training, in residency, fellowship, or attending. And there's all sorts of research being done, a lot of talk about microaggressions and things like that. And it is fascinating. And one of the things that I thought was interesting and really kind of sad is when the surveys came out and were taking people for a little further along in practice, who in their head thought, oh, it probably wasn't that bad. And they start answering the questions and hearing the stories, they're like, oh my God, it was awful. And they didn't even recognize how some of those micros were really macros, or they just normalized it. And it's really just not okay. I'm also part of the surgeon moms group, and it's phenomenal. That's obviously not just ortho, but everybody. But the awareness is something. There's a lot of places that have gone to taking their first names off the badges. We would have said, I'm so tired of people calling me by my first name, or sweetie, or honey, or whatever the first name is. They made their institution take their first name off the badge, or put the word doctor in front of their first name. There are certain such things, but craziness. I was so excited to give you a hug beforehand and say, I'm so excited to hear a topic. And she's like, I'm not worried about the public speaking, but she did say, I'm very interested to see what the responses could be. One of the things that just, you're asking as a male, how can you help? Within the Women in Ortho discussion, we just elected our first ever female head of our academy, American Orthotics, which is the biggest badass tumor orthopedic surgeon who happens to be female. And she said the culture has to change and it has to start from the top. To really encourage the leadership, the administration. And we're really trying to focus on, it's not superiority. We're not trying to promote, has been think maybe that's different from practice. Elevate everybody to that level instead of sort of these tribalistic and things like that. But really, it has to be a whole sort of culture change. So I would encourage you and empower you, and I love that you address the things and medical concerns first, but not letting it get swept under the rug, because that's not going to help anybody. And there's a real he or she hashtag movement within the female surgeon staff of Ortho of identifying those mentors and recognizing that as men, it's also your responsibility to elevate our entire profession equally and not let it feel like it's we have to have a woman there, but it's let's be open on the opportunity. That's way longer than I said.
No, thank you very much for that comment. Thank you very much. My husband is a urologist, and he was rounding. I want to share a story too that kind of speaks to that. He came home so upset because he was rounding one day. He had one female resident and one male resident with him when he was rounding, and they were rounding on an elderly male patient because most urologists see elderly male patients. And the man turned to the female resident and said, "So are you married?" And she said, "Well, yes." And he said, "So do you have any kids?" And she says, "Well, no." "Well, at least you did one thing right." And my poor husband was mortified and just did not know what to say and came home like, what should I have said? And so I say this because I think it's helpful to have retorts ready, because sometimes you're so taken aback by something you don't know what to say. I said, "Well, you should have turned to the male resident and said, 'So are you married? Do you have any kids?'" And treat them equally, because when you treat people equally, people can see, use humor. I love to use humor to de-escalate, but then make it clear that I'm going to treat both my residents the same way. Any other comments? Yes, please.
Mine's more of a question for you and the other women in the room. But in my continuity clinic, I get called Miss a lot by moms all the time. And I try to be humble in most of my practice, and so I don't correct them. Do you correct them? Should I correct them? Would you recommend that? I usually just kind of let it pass and move on.
Okay, for the people that I'm repeating this because it actually is a question. It was really hard for me to repeat all of the stories for the people on the phone, but the question is, when you are called Miss as a woman, would you correct that person and ask them to call you doctor? I actually want to open this discussion to some of the more senior women in the room, because I'm just as humble as you are. I couldn't ask my Taekwondo instructor to change the name on my belt. So does anybody have a solution to that? I mean, I guess the solution, we just have to do it, but.
I know when I'm supervising people, or when I've had supervisors, the supervisors will repeatedly refer to the female resident as doctor over and over to the family. Well, Dr. Smith said this, and Dr. Smith, the family keeps turning to the resident and calling her that.
Yes.
But I think that's easier for someone else to do by doing it for yourself.
Yeah, I'd really like us to give up that imposter syndrome and get comfortable with saying it ourselves. Just don't know how we're.
In the clinic, you're usually by yourself.
Yeah, there's no one else. That's right. Dr. Swoboda first, and then, yes, go ahead. Dr. Swoboda.
I've struggled a lot with this in clinic, and I can't tell if it's a cultural thing or if it is really just because I'm a woman. And I initially didn't. I was like you. I was like, no, I'm just going to let it go. I'm the doctor. I introduced myself as doctor at the beginning. And as I've gotten more confident as I'm attending and in my practice, I do correct them now, because I don't want them to come back and not understand the authority that I have or the training that I have to try to help them to do what we're trying to do for their child. And I feel like I've earned that respect now, and I have more confidence in correcting them. And I wish that I could have told my younger self that it was okay to do that as well. But it does happen. Even when I correct them, sometimes it's still, oh, Miss Swoboda, what are we doing? And it's really hard. And so I do it once or twice, and then if it doesn't catch, I just let it go and chalk it up to, I've made my point, I hope, and that's about all I can do, and then I move on. As long as they understand that I'm here to help them, and I do have this training, and I would like that respect. If they don't pick up on that, then I have to let it go.
Thank you. Dr. Vidauri.
Yes, I think most of the times when we round as a group, probably they're able to see it, but sometimes I let, we have fellows, and so they independently round. When I come back myself, I usually catch them on the phone. I'm like, oh wait, Mom, I gotta go. The nurse just walked in. And that, it makes it super easy. I'm not sure your doctor, because then they think they never saw an attending, and we get that all of the time. The comments like Dr. Stewart just said, they just literally believe that they haven't seen a doctor all day, and they've had like a ton of doctors walked in, and so you have to correct because then they keep on thinking that. And so I'm like, I'm actually your doctor. I'm the supervising doctor today. You've seen so many, but I'm the supervising one. And so I usually do, because then we get complaints like that all the time. And so for them to know that they actually did see somebody, I do. It's hard.
It is hard. Thank you. Dr. Gadea, did you have something to say?
I was actually about to say exactly what Dr. Swoboda just said. I think, when I was younger and like definitely in residency, maybe early attending, I didn't correct them, and it was easier to just kind of let it pass, and it kind of felt weird to correct them. But I think over time, I've come to realize the importance of that, and that I have earned that title, and also in order for them to know that I am the physician, I am the one that's providing your care. And so and it gets easier. It's a little awkward initially, but it gets easier once we start kind of getting that new routine.
Yeah, I want to share a few things as well. Like, I actually came from Nepal, and I actually went to the medical school in Nepal, right? So, I mean, talking about female, upbringing, and then, female in a good spot is pretty lower than here, of course. So, I mean, interestingly, whatever the team I was on in my medical school, like we used to have a group of maybe 10 or 15 medical students, and I was, among those 15, like male were only 5, and then almost 10 or 12 would be females. I mean, like I still remember most of the female in that group would be called the nurse or man or something like that, and then we were not even the doctor at that time, but we were called the doctor. So our female friends used to be really, really sad for that. And then like looking that picture and looking things over here, it's way better here, and then that's kind of very reassuring, But at the same time, there is a whole lot of things that we can actually do to improve this to a better spot, right? So I think the big message is it's getting better, and then we need to be happy for that too, for the women empowerment. But at the same time, we can still work better to make it to a better spot.
Thank you for that. Yes, I went to medical school in India, and more than 50% of the students were female. And I was always assumed the nurse and called sister. And when I spar with my husband at Taekwondo and we trash talk, he calls me a nurse to trash talk. Dr. Castanini.
One of the arguments I've heard, and I disagree, is that women do not want leadership positions. They prefer not to take them. And that's why you see those differences in the statistics you've shown. Not because they're not given the opportunity or just because they could not rise to that, just because they don't want it, because they want to be, the family. That's an argument I've heard many times. I think I disagree. So I would encourage you to include a poll everywhere that says, for the male in the room, if given the opportunity, will you take a dean position? And for the female, so you will show that a lot of the females I'm sure in this room will take that opportunity if they will be offered that opportunity.
That's a really good idea. I'll probably replace my Oprah and Clooney slides with it. Those are probably more helpful. Yes, Dr. Petrescu, and then we'll come back over here.
Language is funny. For instance, even if you say my first name, to me, like for openness and closure, and if you say doctor, you can put a bit of distance. Yes, brings a bit of respect, objectivity, but also brings distance. Like, for instance, I call Dr. Morse. I will never say Martha, but I call Felix because
Okay, so that's a really good point. Oh, it wasn't artificial. I promise, Melissa. No, that's a very good point. And actually, there was a comment that on one of my slides that I did not speak. I wanted to make sure we had enough time for discussion at the end. But what we choose to do in our local culture is a different story. If you want to call Dr. Chardonofsky, I call him Dr. Chardonofsky, Felix, and you want to call Dr. Morse, who I also call Dr. Morse, Dr. Morris, then that's a relationship you have between the two. The bigger issue is when we're on a larger professional scale, when we introduce women by their first names, but men by their title doctor. That's a different story because it sets the stage for that lecture that the woman is not an expert in this topic. Do you understand the difference? I called her Dr. Svoboda right now because we're in this room, but she's Melissa to me. Perhaps I'm not explaining that, but Dr. Garcia has a comment, so let's see what she says. And I call her Allie at home.
Well, as we were saying, in a professional setting or in a conference setting, you introduce somebody as doctor versus maybe first name. But even in that conference setting, and I find this an interesting exchange, when you're not presenting, you're off to the side or later after conference, and people are hanging out, and maybe the men do present each other as first name and then a woman as doctor, but that creates that little separation. And that is part of advancing within a society. So now you're talking about we're friends, not just colleagues, and I'm talking about going to a national conference, and most of the learning and the true interaction sometimes happens at the sidelines, right? At the cigar bar afterwards, at the golf. And if you don't play golf and you don't smoke cigars, you probably aren't going to get involved with them. And if you talk sports, you are. My personal experience is I'm not very interested in American football, although because I have a husband that is, I actually can talk a little bit about it. But I'm fascinated with soccer, and when that comes up, all of a sudden I can talk on the sideline about something, and that turns into a conversation about, oh, by the way, I have this case, and what do you think? And sometimes it's hard to manage that. I still think that's something we can do as a medical profession, realize that it's not just how you present at the actual conference, but how do you manage your own social colleague professional circle.
It's a very good point. I know we could sit here and talk about this for another half hour, but in the interest of time, I'm going to end the conference. I want to add one last plug. Many of you might have received an email about a Women in Medicine group that we're trying to put together here that Dr. McLaughlin, Dr. Gadian, and I are putting together here. We hope to send the e-bite out soon. We'd all like to sit down and talk about things like this a little bit further. August 29th, I'll send an e-bite out. But thank you all for coming and for all of your comments. I'm really interested to hear how much passion there is about this topic. Thank you.
Thank you.
That was nerve-wracking. That was a good talk. Thank you.